Mujib Medical University, and the panel of experts will be Dr. Mohammad Kobi, Dr. Dulal Chandra Das, Dr. Mohammad Faradul Islam Chaudhary, Dr. Pankaj Naha, Dr. Naurana Khalek, Dr. Pallab Kumar Dotto, Dr. Jhumur Ghosh, and Dr. Muhammad Afzal Hussain. I now the first presenter will be Dr. Ashik Ahmed Bhuiya. He is an hepatologist and working as now Assistant Professor, Department of Medicine at Universal Medical College and Hospital, Dhaka. So I request moderator, Professor Dr. Mamun Mahatab Shapnil sir, to take up the mic and say something.
Thank you, Dr. Patso. It is our immense pleasure to have you all here today for this webinar. We are expecting some exciting lectures updating on the nomenclature and management of NAFLD as well as HCC. So, without delaying any further, it is now my pleasure to invite Dr. Ashik Ahmed, Assistant Professor of Hepatology at Universal Medical College, Dhaka, to present his talk on updated management on hepatocellular carcinoma. Dr. Ashik, please.
Thank you, sir. Distinguished moderator, panel of experts, and my dear colleagues. Assalamu alaikum and good evening. I am Dr. Ashik Ahmed Bhuiya. We have a large ground to cover. So without further ado, let's start our updated management of hepatocellular carcinoma. Hepatocellular carcinoma is the 6th most common cancer worldwide. It's the 4th most common cause of cancer mortality. Its highest incidence is in Asia, 76% of all cases worldwide. It has a significantly low survival attributable to its late diagnosis. It has a 5-year survival of less than 5% without treatment. The risk factors being cirrhosis, increasing age, and male sex. This is a study showing the distribution of hepatocellular carcinoma among all other liver diseases. This study was done by our moderator, Professor Mahatab Shapnil sir. He is well aware of this study, where they found out that amongst all liver diseases in Dhaka, 8.4% cases are of hepatocellular carcinoma. Whereas in Chittagong, it's 8%, in Sylhet, it's 0.6 to 1.36%, in Rajshahi, it's 2%, in Borishal, it's 5%, and in Khulna, it's around 4.8%. We are all acquainted with this flowchart of the BCLC staging of hepatocellular carcinoma in cirrhotic liver. I will not go into the details of this flowchart because during our course of the presentation, I will talk in details about every step. What we have to understand here is that in the prognostic stage, there are very early stage, intermediate, advanced, and terminal stage. And among the treatment part, ablation, resection, transplant, chemoembolization, systemic therapy, and supportive care. These are the main treatment modalities that we select for patients of hepatocellular carcinoma. So what principles should we follow while treating a case? First of all, we have to, after multidisciplinary team evaluation, treatment has to be individualized. The treatment decision will depend on the ECOG performance status, the preserved liver function status, that is emanated by CTP-A and CTP-B of less than or equal to 8 without ascites, and finally the surgical feasibility as denoted by the perioperative mortality of less than 3%, morbidity of less than 20%, post-surgical severe liver failure incidence of less than 5%, and a CTP of A and MELD score of less than 10. Before we go into the treatment part, we have to understand the ECOG and Milan criteria, which will come regularly during our presentation. What is ECOG performance status? We have to denote the ECOG performance status by these 5 points. 0 is patient is fully active without restriction. 1 is activity restricted, but patient is ambulatory, he can perform light work. Then 2 is ambulatory with all self-care, but no work activities, and patient is awake more than 50% waking hours. 3 is limited self-care confined to more than 50% of waking hours, and 4 is completely disabled. This chart is determining a treatment modality for a patient of hepatocellular carcinoma. Then comes the Milan, which is important for transplantation purpose. A single tumor of less than 5 cm, 2 to 3 tumors, none exceeding 3 cm. And finally, no vascular invasion and or extrahepatic. So what modalities do we consider nowadays for treating hepatocellular carcinoma? There are some curative therapies, loco-regional therapies, systemic therapies, and others. Curative therapy is ablation, surgery, and liver transplantation, whereas loco-regional therapies are transarterial chemoembolization and transarterial radioembolization. There are some systemic therapies and other therapies like immunomodulatory and stereotactic body radiation therapy. First, we'll start with the curative therapies. Who are the optimal candidates for a curative therapy in case of hepatocellular carcinoma? The BCLC0 stage, that's a single tumor of less than 2 centimeter, or A, but within Milan criteria. The patient should have a preserved liver function and performance status has to be 0. This is the most important point being here. What are the ablation therapies? Ablation therapies are the first stage of the curative therapies, or the first available to hepatologists are percutaneous ethanol injection or PEI, radiofrequency ablation or RFA, microwave ablation or MW, focused ultrasound. First of all, let's talk about the percutaneous ethanol procedure, where under ultrasound guidance we inject the patient into the tumor and inject ethanol, which induces a chemical coagulative necrosis. It's usually suitable for less than 2 centimeter lesion in CTPA group, but it has a high tumor recurrence, the contraindications being gross ascites, severe thrombocytopenia, and coagulopathy. Then comes radiofrequency ablation or RFA, which causes heat-generated necrosis. The needle is inserted under imaging or surgical guidance. The temperature ranges between 60 to 100 degrees Celsius. It's not effective in lesion adjacent to blood vessels, resulting in burn. It's combined with other loco-regional therapies in cases of tumor more than 3 centimeter size. And it's better than percutaneous ethanol injection if the lesion is more than 2 centimeter. Here is a graphical representation of RFA, where we can see the RFA probe is inserted under radiologic guidance. And once the probe is inserted, the electrodes are deployed from the probe, which results in a coagulative necrosis. And finally, the tumor cells are destroyed and will eventually be replaced by scar tissue. Then comes microwave ablation, which uses electromagnetic energy. It induces a higher local temperature. It causes less periprocedural pain. It has a more predictable ablation zone, and it's less susceptible to heat sink effect. This point is important. It has a shorter procedural time. Surgical clips or pacemaker are not a contraindication, and no grounding pad is required as opposed to RFA. But what we have to consider here is that cost of RFA probe is lesser than microwave ablation. We can see here that the RFA probe has multiple electrodes, where microwave ablation is a single probe. That concludes the ablative therapies we use in hepatocellular carcinoma. Then is surgery, which is another curative option in cases of hepatocellular carcinoma. So before going into surgery, we have to do the pre-operative assessment. That is, we have to determine the extent of tumor involvement either by dynamic CT or by MRI. We can also do a CT chest or bone scan only if the tumor is more than 5 centimeter, it is subdiaphragmatic, or there is vascular invasion. Underlying liver function has to be assessed to predict post-operative mortality and prognosis. This can be determined by the MEL score and CTP score. This is a very interesting diagram taken from the European Association for the Study of Liver Hepatocellular Carcinoma 2018 guideline, which shows if the patient has no portal hypertension and we have to do a minor resection, MEL score less than 9, he is a low risk patient. There is 5% risk of liver decompensation, and the liver related mortality is 0.45%. That is, he is in the green zone. But the same patient with no portal hypertension, if we have to go towards a major resection, then he moves towards the intermediate risk, where the risk of liver decompensation is less than 30%. Whereas presence of portal hypertension immediately moves the patient to an intermediate risk part. That is, although if he does need to undergo minor resection, he is an intermediate risk patient. That is, there is less than 30% risk of liver decompensation. And finally, with portal hypertension, if we have to perform a major resection, it causes high risk of liver decompensation. That is, the post-operative mortality and morbidity will definitely be higher. So, to conclude, considering surgery in a patient of hepatocellular carcinoma, if a patient is child POA without significant portal hypertension, he is a good candidate for minor or major liver resection. And carefully selected patients with child POB and or portal hypertension may be candidates for minor surgical resection. But child POC patients are not suitable for surgical therapy, and when a patient is undergoing surgery, laparoscopic resection is better than open resection. So we just talked about radiofrequency ablation and liver resection. These two modalities are mostly used. So how do they compare and contrast in relation to each other? RFA is less invasive. There is less complication. There is a short hospital stay. It's cost effective, and it's more beneficial for tumor more than 3 centimeter. But here we have to consider RFA in combination with other local regional therapy. It has a high recurrence rate. There is probability of needle tract seeding, and it is not suitable for specially located tumor such as underneath the liver capsule or adjacent to gallbladder or diaphragm. But it has a similar efficacy to liver resection in child POA or hepatocellular carcinoma of less than 3% size. Whereas liver resection is invasive, there is more chances of complication, there is a longer hospital stay, it's cost ineffective, and the resection unrelated to site, we have to provide it that the remnant liver volume is good. There is less recurrence, and it allows identification of histological parameters that predict the recurrence risk. So to conclude, for patients with hepatocellular carcinoma of 3 centimeter or less, RFA may be an alternative to liver resection because of their comparable long-term efficacy. Then liver transplantation, the final curative option in patients of hepatocellular carcinoma. The first-line option is considered the first-line option in hepatocellular carcinoma within Milan criteria, but unsuitable for surgery. It has an excellent 5-year survival rate of 65 to 80%, but only in cases meeting conventional Milan criteria. One important thing to consider is the bridging and downstaging. It should be sought whenever possible. We'll talk about them later. So what is the Milan criteria? It is the criteria most commonly used for liver transplantation. This is more commonly used in deceased donor liver transplantation. Here, the single tumor size of less than or equal to 5 centimeter or 2 to 3 tumors none exceeding 3 centimeter, and there is no vascular invasion and or extrahepatic spread. Another criteria is UCSF's criteria, where the single tumor is less than or equal to 6.5 centimeter or 2 to 3 lesions, none exceeding 4.5 centimeter with total tumor diameter of less than or equal to 8 centimeter, and no vascular invasion and or extrahepatic spread. So what happens when the lesion is beyond Milan criteria? Here comes the question of downstaging. Downstaging gives us some advantages, that is doing liver transplantation on a criteria, that is Milan criteria, that has been prospectively validated. And it also gives us time to study the biology of the disease. HCC recurrence after liver transplantation occurs in 8 to 20% of the patient, and mostly within the first 2 years. It's related to pre-liver transplantation tumor stage and unfavorable tumor biology. And majority represents metastasis from the primary tumor. After the curative therapies, now comes the loco-regional therapies. Who are the ideal candidates? First of all, they are the BCLC-B or multinodular unresectable cases with preserved liver function and performance status of 0. These 2 points are important. That is, preserved liver function and performance status is 0. The different modalities used here are transarterial chemoembolization or TACE and transarterial radioembolization or TARE. Transarterial chemoembolization is something that we are most excited about nowadays. It's a catheter-based delivery of chemotherapeutic aid drugs to the arteries supplying the tumor. It's combined with the delivery of embolic material for the containment of reduction of arterial inflow, and its combination of transarterial embolization with chemotherapy. There are 3 components. First is the embolic agents, that is gelatin sponges, polyvinyl alcohol particles, and microsphere. Then there is lipiodol, which is the oily contrast medium and the carrier of chemotherapeutic agents. And finally, the chemotherapeutic agents such as doxorubicin, cisplatin, and idrarubicin. Idrarubicin being the most potential agent for now. There are usually two types, that is the conventional and drug-eluting bead stays. We can further divide the conventional stays into selective, super-selective, and ultra-selective. Selective being done in the segmental hepatic artery, super-selective in the subsegmental hepatic artery, and ultra-selective in the distal most subsegmental hepatic artery. What are the indications where we can use transarterial chemoembolization? As shown below, before, BCLC-B or intermediate stage, then BCLC-A, where ablative therapies have limitation, and for downstaging and bridging to transplant. What are the absolute contraindications? The absolute contraindication being child PO score of more than 8, portal vein thrombus, hepatophageal flow, creatinine of more than 2, untreatable arteriovenous fistula, and extensive tumor involving both lobes. Now comes the downstaging and bridging. We just talked about them before. What is downstaging? Downstaging is treatment intended to reduce the tumor stage from beyond to within accepted transplant criteria and allow transplantation. And bridging is treatment intended to maintain patients already within accepted transplant criteria and to prevent dropout due to tumor progression when waiting time is more than 3 months. This point is important. What is the aim of downstaging and bridging? The aim is to achieve 100% tumor necrosis. However, in only 30% of cases, we can achieve 100% necrosis. Where HAP score is more than 2, it shows poor transplant outcomes. So comes the question, what is HAP score? HAP score or hepatoma arterial embolization prognostic score is a simplified validated score which is able to define 4 distinct prognostic groups with respect to survival and could be used as a stratification factor for TRACE trials in future, which shows a poor survival in score of less than or equal to 2. Only albumin, alpha-fetoprotein, bilirubin, and tumor diameter of more than 7 cm is used for the HAP score, so it can be easily calculated. And patients having HAP score of less than 2 is predicted to have poor outcomes for TACE. So what are the complications of transarterial chemoembolization? The complications are post-embolization syndrome in 90% patients, denoted malaise, nausea, vomiting, and right upper quadrant pain. There is risk of liver failure. There is risk of biliary structure, more in drug-eluting bead stays, hepatic artery injuries, pulmonary embolization, and chemical pneumonitis, risk of infection like liver abscess, myeloma, or sepsis. This is a radiological representation of TACE where we can see that the super selectively the A71 and A72 arteries are being injected with chemoembolization, and here we can see the presence of lipiodol in the necrotic tissue. Another radiographic representation of TACE where we can see the presence of lipiodol contrast medium in hepatocellular carcinoma, and finally the necrosis occurring after doing the TACE. So what about drug-eluting bead TACE? It sounds interesting, right? But drug-eluting bead TACE, despite having the theoretical advantage of causing less side effect due to the usage of beads as carrier of chemotherapeutic agents, have failed to demonstrate any substantial benefit in prospective trial over conventional TACE. Then transarterial radioembolization or TARE. It's a loco-regional radiation treatment which minimizes complication associated with radiation. 90Y microsphere is used and 2 radioembolization agents are available globally like SARS spheres and THIN spheres. It has pure beta radiation emitter and minimum embolic effect, so can be used with portal vein thrombosis. This point is important. We cannot do TACE in portal vein thrombosis, but we can do TARE. But it is yet not recommended over TACE in any guideline. Why is that? Because it's only possible to do in 2/3 of the eligible patients due to excessive pulmonary 99M technetium macroaggregated albumin shunting, and the contraindications being the macroaggregated albumin scan that demonstrates the potential for more than or equal to 30 gyri radiation shunted to the lungs, prior radiotherapy to the lungs, encephalopathy, biliary obstruction, and child PO-C. So what happens when we combine TACE with sorafenib? The first trial was SPACE trial, which showed no difference. But then comes the tactics trial, which showed significantly improving survival over TACE alone. But the important thing to note here is the response evaluation criterion were changed. Intrahepatic new lesion was not regarded as progression, and trial was continued until newly defined progression, and pre-treatment with sorafenib for 2 to 3 weeks before initial TACE was done. This is a slide which really makes me proud. It was done by our moderator, our Pramlal Mahatab Shopnin sir, our mentor, which showed the treatment by transarterial chemoembolization and sorafenib for hepatocellular carcinoma versus advanced hepatocellular carcinoma in Bangladesh. This was just an observational study with very showed that a total of 77 patients of and treated with TACE and sorafenib at the same time. And after 3 months of follow-up, out of 77, an additional 15 died within 3 months after therapy commenced. Thus, 44 survived patients remained after 3 months, which is a very significant data to me. Then comes the systemic therapies. Who are the ideal candidates for systemic therapies in hepatocellular carcinoma? They are the BCLC criterion, portal vein tumor invasion, patients with extrahepatic spread with preserved liver function, and performance tyrosine kinase inhibitor, the most common being sorafenib, is used at a dosage of 800 mg a day. Overall, 15% are sorafenib intolerant and another 35% require dose reduction. Survival advantage is only of 3 months and overall response rate is 10%. If we divide them into 2 lines, the first line therapy is sorafenib and lenvatinib. Lenvatinib is non-inferior, but it does not address the portal vein invasion. And the second line therapies being cabozantinib, nivolumab, pembrolizumab, regorafenib, and ramucirumab. The important thing to note here, in cabozantinib, sorafenib intolerant but progressive disease cabozantinib can be used, and sorafenib tolerant but progressive disease regorafenib can be used. So what are the roles of immunotherapy in HCC? This is the cutting edge stuff. The FDA has recently approved atezolizumab in combination with bevacizumab for the treatment of patients with unresectable or metastatic hepatocellular carcinoma who have not received prior systemic therapies. Other therapies which are still on the pipeline are ipilimumab, tremelimumab, nivolumab, and pembrolizumab. And finally, stereotactic body radiation therapy, or SBRT. We all know that liver is a radiosensitive organ. It delivers radiation. In this therapy, we deliver radiation from different angles to focus radiation at one small point. It's not yet recommended in any guideline, but it may have a role in a subgroup of patients with portal vein thrombosis and hilar lesion where the patient is unfit for TACE. So to summarize, surgery is the treatment of choice in very early HCC and HCC in non-cirrhotic patients. RFA is equal to surgery for lesions in less than 3 cm. Beyond that, it should be combined with other modalities. TACE as a treatment modality to downstage or bridge to transplant has immense potential. Milan criteria is the most definitive and prospectively validated criteria for liver transplantation. Systemic therapies have limited survival advantages up until now, and role of immunotherapy is promising. And that about concludes my presentation. I would like to express my gratitude to my mentor, Professor Maunal Mahatab Shopnil sir, because most of the data I have shown here have been taken from him. I would also like to express my Professor Anil Arora from tried my potentials of hepatocellular carcinoma in this study, and I'd like to thank everyone for their patient hearing.
Absolutely. Thank you, Dr. Ashik, for the excellent presentation. But before we go on to the Roy Hepatology Chapter or the medical
Uh, Welcome everybody. I first thanks to my teacher, Professor Mamunal Mahatab Shapnil, for giving me the opportunity to present this topic, and then I thanks Dr. Ashik for his excellent and elaborate presentation on update management of hepatocellular carcinoma. Are my slides are visible?
Yes, Partho, your slides are visible.
Okay, thank you. So before going to the presentation, I want to say that NAFLD or NASH is very difficult to present. With the emerging epidemic and of obesity and our changing in the lifestyle management, the spectrum of NAFLD and NASH is increasing day by day. So not in Bangladesh, but throughout the world. And it is very difficult to, there is extensive research from the molecular pathogenesis to updated clinical management, drug development, and non-invasive biomarkers development. So it is very difficult to present as a compact presentation. I will focus on some points which can create a thoughts process, debate, and discussion. So first of all, what we understand about NAFLD and NASH is diagnosis of NAFLD needs steatosis more than 5%, we all know, but NASH requires a specific pathological criteria. That means if we can find lobular inflammation, hepatocyte ballooning, and fibrosis, we can call it NASH. And it also required exclusion of the secondary causes of fatty liver disease and also alcoholic fatty liver disease. So that means still today, as this one of the most prevalent disease of this world, it is a disease of exclusion. I think probably no other disease in this world which is so much prevalent is a disease of exclusion. So comes to the new nomenclature which have been proposed by 22 hepatologists from 22 countries around the world, which have proposed in just June 2020. They have renamed this non-alcoholic fatty liver disease to a spectrum named metabolic dysfunction associated fatty liver disease. That means MAFLD. So the diagnosis is now not in exclusion, it is a positive diagnosis. Any patient with hepatic steatosis, either with obesity or type 2 diabetes mellitus, is ultimately muffled. The problem arises when the patient is normal or lean weight. In this case, we have to found at least two metabolic risk abnormalities within which there is waist circumference, BP, lipid profile, diabetes status, and HOMA-IR, and plasma high sensitivity C-reactive protein. Any of these two category with hepatic steatosis in adult ultimately goes to NAFLD. So there's to that in our student life, from our student life, we categorize that cryptogenic cirrhosis meant NAFLD related cirrhosis. No, this has come to a definite diagnostic criteria. That's what imaging. Any of this cirrhosis with an 5 years ago ultrasound or fibroscan report, you can categorize it into NAFLD-related cirrhosis. So what will the other causes, like any patient with a concomitant alcohol use, B virus, C virus, we can categorize it into dual etiology fatty liver disease. So this nomenclature is very new, and what to be decided is still pending. So throughout my other presentation, I have used the common nomenclature, that is NAFLD. So the natural history of NAFLD, we all know there is stages. It is start from steatosis, then steatohepatitis, then fibrosis starts, progression 25%, 7 to 8 years, then from cirrhosis to it turns to decompensation, that is 25% in 8 to 10 years, then decompensation to HCC 1% per year, sometimes 1 to 3%, and this leads to ultimately death. But there is the pattern is the scientists are not talking about that not all patients of this NASH ultimately progress to fibrosis at similar level. There is some patients who progress very slowly. They are called slow progressor. That means they have reached into F1, F2 fibrosis, remain in that F1, F2 fibrosis for long periods, maybe lifelong. And whether they can turn to advanced fibrosis is still unknown or debated. But some of around 10 to 20% of this NASH patient progress rapidly within 5 to 6 years with advanced fibrosis, that is F3, F4, that is called rapid progressors. And most of these patients of rapid progressors ultimately turns into cirrhosis and decompensation. So this is the global burden of the NAFLD and NASH. To summarize that, worldwide prevalence is 25%. Any prevalence of NAFLD in normal population, you just multiply with it 2, it turns in the prevalence in type 2 diabetes mellitus. So in type 2 diabetes mellitus, 55.5%. Prevalence of NASH in general population is 1.5 to 6.5%, but in this case, type 2 diabetes mellitus NASH is 6 to 30 times higher, that is 37.3%. Highest is still in Middle East, 31.8%. Second, South America, 30.5%. What about Asia? Still, the largest group of NAFLD resides in Indonesia, 51.4%. Second to Hong Kong. Bangladesh remains in the intermediate stage, that is 33.86%. Close to India, which have a very heterogeneous group, 32 to 74% of NAFLD. Now, I will not go to details of the symptoms and signs of NASH. I will just showing this slide for one single information. This, according to this meta-analysis published in 2019, fatigue or tiredness is the most common symptom of the NASH. So, any patient with an FLD with fatigue and tiredness, evaluation for NASH is very urgent. So then come the part of the evaluation. Should we go for liver biopsy? Should we go to non-invasive test? The debate is long-standing, and there is still no definite spectrum of this debate. So in 2019, ASLD have organized a particular debate, like we have debated in our college life. 6 hepatologists, who are specialized in fatty liver disease, are grouped into non-invasive test. 6 hepatologists into liver biopsy side, and they have put all the data in favor of their own spectrum. So I will first start with the non-invasive test. They have already published this article in 2 formats: pros of liver biopsy, cons of liver biopsy. So first with the non-invasive test, first one is NASH is a slowly progressive disease. As I have shown earlier, that even the rapid progressive disease, it turns to advanced fibrosis within 5 to 7 years, sometimes 10 years. So should we will biopsy every drug which have evolved and have been managed, have been pair biopsy, sometime by 3 years interval, 4 years interval. So how long we will biopsy a patient of an FLD? 3 times, 4 times, 5 times? Indefinitely? That is impossible. Probably the patient will not participate on that. So we will ultimately fall into non-invasive test. And non-invasive test allowing NASH to be adequately monitored over time. We can perform fibroscan every year, 6-month interval we can perform. Liver biopsy for staging for NASH has risk and limitation, as have been shown that there has been severe adverse effect like hemoperitoneum was found in less than 1% cases, even in death. And non-invasive testing is accurate, cost-effective, and reliable. But still, points in favor of liver biopsy is still stronger than non-invasive test. Why? NASH itself is a histological diagnosis. And for this reason, all the pharmacological treatment yet approved, still approved in the guidelines as after liver biopsy. And a liver biopsy is not as dangerous as you think. They have shown that severe adverse effect in a liver biopsy is less than a polypectomy bleeding. And non-invasive assessment modalities have multiple pitfalls like operator dependency. So next, I have shown that, so when we will ultimately biopsy the liver, I have shown 2 guidelines, 2 recommendations, one from East INASL in the National Association of Study of the Liver, one from the West ASLD. ASL has given a group of indications for liver biopsy, and ASLD has tried to bridge this non-invasive parameter to sort out which patients ultimately require liver biopsy. They have said that the presence of metabolic syndrome, NFS 5-4, and liver stiffness measurement by tangent elastography may be used to identify the patient who are risk for steatohepatitis, and that may need liver biopsy. So here there is a bridge that the non-invasive test can be used as a bridging for liver biopsy. So what are the non-invasive tests and biomarkers available? We can categorize into wet, that means that need blood, and is dry, that means it need imaging. So the blood biomarkers is fatty liver index for every stage: steatosis, steatohepatitis, fibrosis. Steatosis, fatty liver index; steatohepatitis, CK18, NIS4; fibrosis and cirrhosis, FIB4 and NFS. We will come to that later. Dry biomarkers mean ultrasound, fibroscan, and MR elastography. So now come to the most commonly approved the non-invasive biomarkers, blood biomarkers. These are called point of care. Why? You can calculate this biomarker residing on your chamber within just 30 seconds. You just download a QX calculator or go to the website and you can calculate this all of these three parameters in your chamber just 30 seconds. For FIF4, you just need 8 AST ALT platelet count. More than 3.25 is F3 F4, less than 1.45 is F0 to F2. For calculation of FP, you just need AST and platelet count, just CBC and AST, less than 0.5, the greater the negative predictive value of fibrosis. NFS needs some other parameters like BMI, age, diabetes mellitus, AST, ALT, platelet count, and albumin. It is still available into our district level, and if the cutoff value is less than minus 1.45 is F0 to F2, more than 0.676 is F3 to F4. Transient elastography, the most commonly we hepatologists use, is accurate in detecting advanced fibrosis, not in early fibrosis, not F1, F2, F3, F4. So the area under the curve was 80% more than F2 and 85% for prediction of F3. Predicts the risk of decompensation. It also correlates with portal pressure, most widely used, and we can also measure CAP. CAP measurement progressively increase with number of METs components. Suppose a patient with only an NAFLD, the CAP may be 270 to 280. If the patient is NAFLD with diabetes, it may be more than 300. If patient is NAFLD diabetes hypertension, it may be more than 350. So CAP, higher CAP means higher component of metabolic syndrome. So if we turn this whole evaluation into a group, these have been taken from our one of the most comprehensive textbook, Joachim Boyer, that suspected NAFLD. If we calculate the NFS, some group of scientists believe you can use at least two score, NAFLD, NFS or NFS or FIF4. If it is low risk, that is in case of NFS less than minus 1.45, you just go to the low risk category. If it is intermediate to high risk, refer to secondary care. And after the referral, you can perform that transient elastography, that means fibroscan. In simpler term, fibroscan value, liver stiffness value less than 8, it again goes to low risk. If fibroscan value more than 8, it ultimately goes to intermediate and high risk. For low risk patient, management can be continued in primary care. Lifestyle advice is sufficient. Address the cardiovascular risk and recalculate this score in every 3 to 5 years. But in case of medium to high risk patient, liver biopsy can be done, should be done. And in case of this, again, fibrosis, early fibrosis, we can manage it in primary care. But in fibrosis F2 to F3, NAFLD directed therapy should be added. And in case of advanced fibrosis and with cirrhosis, HCC and variceal surveillance should be started. So now, what are the comorbidities we should know about it? We hepatologists, when treating the NAFLD patient, we also should be treated with multiple comorbidities. We have seen that in every NAFLD patients have 2 to 5 times greater risk of developing type 2 diabetes mellitus, cardiovascular disease, chronic kidney disease, and non-hepatic malignancy with hepatic malignancy. So the number one cause of mortality in NAFLD is due to cardiovascular. Second common cause of disease, malignancy, both hepatic and non-hepatic, colonic, esophagus, stomach, all carcinoma have an increased risk in a patient of NAFLD. Number 3 cause of the death is liver-related death. So we should know to evaluate and manage the comorbidities. So evaluation starts from actively screen for metabolic syndrome, that is fasting lipid profile, glucose, insulin level, blood pressure, heat measurement, and for cardiac evaluation, any symptom of about cardiovascular disease, they can promptly go to cardiac evaluation. And the routine non-invasive testing cannot be recommended, but we can calculate Framingham risk score or other risk score, which we can also calculate in our mobile smartphone just within 1 or 2 minutes. So now when we storm our liver with so many fat, the liver will revolt. We will say that he is not a fighter, he is a liver. So we should calm this. How to calm this? So the management of, always talk about the patient-targeted approach. So we improve insulin sensitivity and inflammation, fibrosis. But now, with the increasing slow pandemic of obesity throughout the world, it has been proposed by several bodies the public health intervention to reduce or management of multi-pronged approach is needed from multi-social approach to need the manage and obesity. So role of diet and exercise, we all know very different. Just to summarize in one concept, not in calculation of fat, calorie, the most important thing is hypocaloric diet. That means a diet should be 11 to 10% weight loss. Any nature of diet and exercise without an appropriate weight loss is not beneficial for treatment of NASH. Why? Now we have the effect of weight loss on NAFLD NASH. This is called the weight loss pyramid. That means if we continue patient loss more than 5%, if we categorize weight loss, increase weight loss slightly more than 7%, total NASH will improve. And if we can continue weight loss more than 10%, fibrosis will regress. But lifestyle intervention should be more than 5 and 10%, 1/10 of the patient. And whatever patient has undergone this degree of weight loss, they cannot stay on that weight. It is called weight recidivism. That means that weight is difficult to sustain. So there is multiple approach. We can approach pharmacologically, which have unfavorable side effect. We can perform bariatric surgery, is still not recommended because only less than 1% qualify for surgery, and there are cost, preference, access, morbidity, and mortality. There have been many interest among the intervention endoscopists about endoscopic bariatric and metabolic therapy, which is called EBMT. It is less invasive, but still no RCT, not recommended in NASH. So how can we manage of other metabolic comorbidities before come to the specific management of NASH? Lipid target is not established. Statin should be given according to a traditional guideline, plus minus omega-3 fatty acid. Diabetes mellitus, pioglitazone should be added. GLP-1 agonist should become on the pipeline. Hypertension goal as the other guidelines. ACE inhibitor and ARB has an inherent anti-fibrotic in liver, so they can be added primary regimen for hypertension. Cardiovascular disease as patients without NAFLD and NASH, and routine screening for non-hepatic malignancy is still not recommended. So standard pharmacotherapy in NASH. We all know details about these two drugs, pioglitazone and vitamin D. I should not go to details. I just want to show you that these both drugs have been studied in non-diabetic patients, and pioglitazone has been done in caution in cirrhosis. Vitamin E is not recommended in cirrhosis. Pioglitazone has less than around 1/4 patient with pedal edema, weight gain, cardiac failure less than 8%, bone loss in female, and there is a very reduced chance of CF urinary bladder. And vitamin E, which has a minute chance of CF prostate and increase all-cause mortality. So we have shown that there is only 2 approved drugs, and which are not totally efficient and totally risk-free, and so this pharmacotherapy is not ideal. So there is an increased amount of drugs are in pipeline. Multiple categories of drug have been investigated. But before showing to the emerging drugs, first I will show that for this drug, evidence is still not in favor for treating NASH. Some of these drugs I have highlighted that you have to remember that these drugs actually may work in other cases, like UTCA, they reduce ALT, Silimarin, they reduce ALT, omega-3 fatty acid, they reduce hepatic triglyceride and blood triglyceride, metformin, they reduce hyperglycemia, lipid lowering agent, they reduce lipid. But for treating NASH, that means histopathological benefit of non-alcoholic steatohepatitis, none of these drugs have still proven beneficial. So what are the list? It is a partial list taken from the clinical trials. You see a number of drugs in pipeline for developing the NASH, so that so many drugs have been investigated that our most favorite textbook of liver, that Sheila Sherlock, have been updated in his recent version, a table that some of the drugs have been performed in phase 3 and published their report. So what are the drugs which are available? Before going to the details, I will not go to details of this pathophysiology. You have to just remember there are 3 categories of drugs. One is metabolic, acting on the metabolic side, all of the metabolic improved function. One is anti-inflammatory, that act on the inflammatory cells. And one is anti-fibrotic, that work in the site of fibrosis or hepatic stellate cell. All of the drugs have investigated either this way or that way, ultimately goes to this T3 category. Now, before going to the most studied drug or receptor transcription factors biology, PPAR and FXR, one of the most fundamentally studied true receptors, is a family of transcription factors involved in glucose and lipid metabolism. What they actually do, they act as a co-activators, so that multiple proteins and enzymes have been formed because of their co-activator of the actions, and ultimate result is increase of the fatty acid oxidation, fatty acid uptake, and this ultimately totally the molecular level of the cytoplasm of the cell. So these two. So now the most promising drug still today is obeticholic acid. Phase 3-2 study have been published and shown a very promising result. This is Flint study and Regenerate study. You see just on the image that the blue is obeticholic acid and the red is placebo. On every effect, histological improvement, resolution of NASH, improvement in fibrosis, every aspect obeticholic acid is better than placebo. So the Regenerate study, phase 3 of this study is also published. We see that at the higher doses, that is 25 milligram once daily, it improved fibrosis more than 38% cases. And not only it decreased fibrosis, it decreased ALT, AST, and gamma GT, and it has also worked in vitamin E non-responsive patients and in diabetic patients. But the side effect profile is not so good. You see the moderate cases, even the moderate side effect and severe side effect is found in 49% cases and 14% cases. For hepatic decompensation and failure for incorrectly dosed with obeticholic acid. In post-marketing reports, they have reported in some cases fatal have been reported in patients with PBC, with decompensated cirrhosis and Child-Pugh B and C impairment. So they have given that 5 milligram once weekly should be appropriate dose for Child-Pugh B and C. And for this reason, still today, FDA has not approved obeticholic acid for NASH treatment. So I have shown that for cirrhosis patient, treatment of NASH is very difficult. So there is a very interesting study in last year, a old drug in a new way, metformin, is NASH cirrhosis with diabetes mellitus. What this study show that this study shows the metformin use is associated with lower risk of overall mortality or transplant and lower risk of hepatocellular carcinoma. But this is a retrospective analysis. Prospective study is needed for further evaluation of metformin. Now another anti-diabetic drug is very on the pipeline, liraglutide, which have been shown very promising result with on 39% patient had resolution of definite NASH compared with only 9% in placebo group. So this drug, it comes from first comes from the Indian scientists, then it have been crossed all of the 3 phases, and now saroglitazar dual PPAR A alpha and gamma agonist has been approved and registered in India for use. Indian hepatologists are using it. You see that all of the result, that percentage change in ALT, absolute change in liver fat content, everywhere it had absolutely very good p-value and very good result. Another drug is Senicriviroc. It is a two large studies, Centaur and NASH Aurora, have been performed, and you see the very promising study. It have been only stage 2 study. Stage 3 is upcoming. So another drug is Senecrivo. Fibroblast growth factor, pegfilgrastim. The important study of this important portion of this study is they don't use biopsy. Rather, they have studied this drug on proton density fraction in MRI. So you have seen that on week 60 there is a decrease at least 56% of fat in liver. Another is thyroid receptor beta agonist, resmetirom. It is another drug which have been evaluated for proton density fat fraction, and is a very promising. It has also crossed the phase 2 study now in phase 3 study. So after all these new and emerging drugs, we should now give attention to some of the comorbidities and some of the other aspects of NAFLD. First is the lean NASH. It seems very benign to naming it lean, but it is not so benign. Lean NASH can be diagnosed approximately 5 to 26% in Asia and 7 to 20% in Western world. It is a more favorable metabolic profile. To describe it in one sentence, the patient is physically not obese but metabolically unhealthy. So this metabolically unhealthy can come from genetic basis, organic basis, or any other profile. So they can develop, as they have favorable metabolic profile than the obese patient, but they can develop the full spectrum of liver damage from NASH to hepatocellular carcinoma. And data on long-term prognosis of lean patients are insufficient and controversial. And adoption of healthy lifestyle is the first category of treatment. Now, NAFLD and pregnancy, it is a very recent study, very important observation that the prevalence of NAFLD in pregnancy has nearly tripled 3 times in the past 10 years, and patients with NAFLD during pregnancy more frequently expected gestational diabetes mellitus, hypertensive complication, postpartum hemorrhage, and preterm birth. So they have recommended that conception counseling, conception counseling, and they may benefit from high risk obstetric management during pregnancy. So how to manage the NAFLD in pregnancy should prompt a careful assessment of pre-existing type 2 diabetes mellitus or gestational diabetes mellitus. Dietary restriction and motivational of physical activity should be carefully managed because there is a risk associated with undernourishment of the fetus. And the drug treatment is not focused on NASH. It is focused on NAFLD with gestational diabetes mellitus. Obeticholic acid and metformin is category B drug. Pioglitazone is category C drug, and vitamin E is not recommended in pregnancy up to if the patient is not suffering from vitamin E deficiency. NAFLD and children and adolescents, we hepatologists are facing a lot of patients, 14 years old, 12 years old, more than 100 kg weight, totally inhabited in a westernized lifestyle. So we have a big problem with these children and adolescents. As early as 2 years, NAFLD has been reported, and cirrhosis have been reported as early as 8 years. Estimated NAFLD prevalence in children is 9.6%. But if we consider increased ALT, then this value reached to 55%. And if a children with fatty liver disease is not overweight, always exclude genetic cause, monogenic cause. This is a recommendation from ASLD. Intensive lifestyle modification is the first line category. Vitamin E may be used, but the risk-benefit ratio should be discussed with each patient, and metformin is of no benefit. ACC screening in NASH, this is a recent guideline from American Gastroenterological Association that the risk of incident in NAFLD cirrhosis is 1 to 3% per year. AGA recommend combining at least 2 non-invasive testing modalities, that is one from blood biomarker, one from imaging biomarker. That you can test FIB4 plus fibroscan, you can test APRI plus fibroscan, you can test NFS plus fibroscan. AGA recommends fibroscan value more than 16.1 kPa for detection of cirrhosis for ACC screening. That above this value, ACC screening should be started. ACC incidence rate is 0.21, that is 0.02% in NAFLD or early fibrosis. Systematic ACC screening is not recommended with NAFLD and earlier stages fibrosis. Choice of investigation, ultrasound with or without alpha-fetoprotein. and any presentation in this time is not complete without telling anything about COVID-19. So there are 3 studies of NAFLD with COVID-19, all from China, and which shows that high prevalence of NAFLD among patients with severe COVID-19, higher risk of progression to severe COVID-19, longer viral shedding time, and risk of obesity to COVID-19 severity is higher in those with metabolic alcoholic fatty liver disease. So I would conclude this as my session with some take-home message. With the take-home message is NAFLD is now the most prevalent chronic liver disease worldwide. NAFLD prevalence in Asia is increasing and is associated with poor outcomes, including ACC and death. MAFLD is perceived as a standalone disease which warrants a positive diagnosis rather than a non-disease rubric. NAFLD is not only a disease of obese, but is typically associated with metabolic dysfunction, also in lean patients. A large proportion of these patients having a clinical indication to undergo biopsy. Non-invasive testing is accurate, cost-effective, reproducible, and allows NASH to be adequately monitored over time. Public health policy to cope up slow epidemic of obesity should be designed and implemented. Lifestyle modification to improve diet, exercise, and weight loss remain the most effective therapy till date. Obeticholic acid has so far been proven superior to placebo in improving fibrosis. It is only effective in 1/4 of the patient, suggesting that additional medications are urgently needed. And it is likely that in future, patients with NAFLD will be treated with a combination of medications like that of hypertension or ischemic heart disease, each addressing a different aspect of pathogenesis of liver disease. I have shown many Western data, but we, the hepatologists from Bangladesh, are not so lag behind from the Western. This is a proof. This is a complete book written by my teacher, Professor Mamunal Mahatab Shapnil, about the fatty liver disease. And I want also added that some of my colleagues, some of them are now the panelists here today, Dr. Jumur Ghosh, Dr. Dulal Dash, and some others have been performed excellent RCT, which have been published in international journal regarding NAFLD. So with this, I have to conclude that we have to fight this epidemic of NAFLD together, and we can combat and ultimately place our stand in international society. So thank you very much, and thank you for attending. And now is the session of question and answer.
Thank you, Dr. Partha. I don't see any questions in the chat box. So I think that both of you presented very nicely and have been able to satisfy the queries that might have been there in the minds of the colleagues who are listening to your lectures. So without delaying any further, let me go on to the panel of experts for the opinion. May I first request Dr. Jahangir Kabir, Assistant Professor of Hepatology at Kumitola General Hospital, for his opinion. Dr. Jahangir Kabir, please. Jahangir, একটু unmute করে নাও, please unmute yourself.
Okay, sir. Sir, can you hear my voice, sir?
We can hear you.
Sir, can you hear my voice?
শুনতে পাচ্ছি জাহাঙ্গীর, বলো।
Thank you very much. First, I give my special thanks to my mentor, Dr. Professor Mamunal Mahatab sir. I also give my special thanks to the Forum for the Study of Liver Disease and Alumni Association of Hepatology of BSMMU for arranging this special session. There are 2 topics just discussed just now, and both the speakers elaborately discussed this matter. I think regarding NAFLD, if I talk some words, NAFLD, regarding management of NAFLD, what is the?
That is the diagnosis of NASH, because NASH is always culprit one. non-NASH fatty liver, this is not so much culprit. So diagnosis of NASH is very much important. Diagnosis or identification of the NASH. And it is actually very much difficult to identification of NASH without histopathology. So this is the main pitfall, I think, for treating NAFLD and NASH. Regarding our hello, there are a lot of scoring system such as BARD score, APRI score to diagnose non-invasive NASH, but none is so much methodical, I think. What is in our clinical practice? Particularly in my clinical practice, I have seen that the patient who are diabetes with NAFLD are more vulnerable, particularly those from diabetes with hypertension, diabetes with dyslipidemic. So I think hypertension with NAFLD and hypertension and dyslipidemia with NAFLD. So if the diabetes associated with NAFLD, I think this particular portion is very much prone to develop NASH and ultimately NASH to cirrhosis. So particularly this, if we seen a patient with diabetes very early stage as well as fatty liver, so we have to, I think, special care for this particular group of patient, because in my clinical practice, I have seen that most of young diabetic with NAFLD already developed NASH and cirrhosis within 40, 45 or 50 years. So it is, I think, one important point. And another regarding HCC, Dr. Asik already elaborate his discussion, but I think a few words. What is HCC? HCC in layman term or in general physician, HCC knows that it is a very notorious cancer. I think, yes, it is really a notorious cancer if it diagnosed in later stage. But if it diagnosed in earlier stage, then a lot of treatment modalities now available. Already Dr. Asif discussed these matters, and some of treatment modalities we have already seen that that these are almost curable and curable also. So early diagnosis of HCC is very much important for management, and delayed diagnosis, I think a lot of modalities also come for treatment modalities, but that is still now so much promising. And another thing is very important regarding HCC. HCC usually one of the most common risk factor of HCC is cirrhosis, and in cirrhotic liver, HCC however very frequently we have seen. So in this sense, HCC is also curable disease. So if we a patient of chronic liver disease, chronic hepatitis patient not progress to cause cirrhosis, then it will usually not progress to HCC also. Although in case of hepatitis B, in chronic hepatitis B stage, it may go to HCC also. So if we prevent cirrhosis, then HCC also preventable to some extent. So what I think, the surveillance of HCC in case of cirrhosis is very much important. Normally, our most of authors says usually HCC surveillance in case of cirrhosis should be done 6 month to 12 month interval. But I think for early diagnosis, it should be monitored more frequently I think it is rather good to surveillance cirrhosis for HCC if we monitor these people 3-month to 6-month interval. I think if the diagnosis of HCC uh, done early diagnosis done, then it is almost a curable disease, and there are a lot of treatment modalities, modern treatment modalities that almost give patient full recovery. So that's all. Lastly, I um, give my special thanks to both the speaker, Dr. Asik and Dr. Patho, for their nice elaborate deliberation. Thank you everybody.
Thank you, Dr. Jahangir. May I now invite Dr. Farhadul Islam Chaudhary, Assistant Professor, Department of Hepatology at Bangladesh Institute of Health Sciences, for his expert opinion. Dr. Farhad.
Thank you, sir. I would like to thank my both presenter for their excellent talk. Can you hear me, sir? Yeah, thank you, sir. And they're very enthusiastic about the presentation and covers all the topics which should be spoke. And one question is to Partha Pratik Rai, should we call it NFLD or MFLD to my professor also? And the thing is that, sir, you have done a lot of things and a lot of study, and it is very important regarding the diagnosis of HCC at an early stage. So the presence of portal hypertension is very important, and we lag far behind from the other countries to diagnose the earlier stage of HCC. What we have found in our patients, they came to us in a later stage, so nothing could be very beneficial for them. What we could do. Can you please introduce in the department for the diagnosis of portal hypertension early? So some methods you have already started TACE and other sort of things. And one question is that should we call it NAFLD or MEFLD down?
Dr. Partha, please.
Thank you, Dr. Farhad, for your nice question. It has been questioned throughout the long after the new nomenclature has been come. It is very early to categorize and renaming all the patients to say MAFLD, because it is still not have been evaluated in all the countries, all the continents, and all the hepatologists have not been in coordination with that. But I say that it is a very inclusive nomenclature. We can use it at least in research purpose, because it is a very good diagnostic criteria for inclusion of any patient, because that doesn't need any exclusion. That is a very inclusive criteria. So at least we can start with this criteria, inclusion criteria, as for management or investigations of drug RCT. We can continue that, and after all the countries and societies throughout the world has accepted this, we can also accept this clinically as well.
Thank you, Dr. Partho. To Professor Maunal Madhav Swapnil, sir, we should have described the modalities of treatment HCC to the other disciplines, which I think we should very much
Yes.
and in the methods of diagnosis and the treatment modalities, and this term, the non-alcoholic fatty liver disease, is still very much ignored by the other departments, very much ignored, and it was rather it was termed, it is nothing. We commonly found, as I am working in a hospital that is the most of the patients are diabetic. We also what we found that all the patients are having incidental, or either it is incidental or they have symptomatic disease. They commonly have non-alcoholic fatty liver disease. Can we start some sort of presentations to them, or we can give some messages to the, especially the internist and the other medical specialists, for the importance of early diagnosis of non-alcoholic fatty liver disease, and as also HCC and the treatment modalities what you have started early in Bangladesh.
Thank you, Dr.
And that's all from
Thank
me.
you, Dr.
Thank you very
Farhad.
much.
Two things that Janish you have raised actually. One is that what we are doing to detect portal hypertension early. If you remember, we had actually started hepatic venous pressure gradient measurement in Bangladesh around 2
Yes,
years
sir.
back.
Yes, sir.
And we were doing it. Then we had some challenges. Challenges means that unless you can start in the government sector, and if you don't follow up, doing in one point is of no good use. You have to follow them up and repeat HPG measurements are necessary. And somehow that was not possible, not so popular an issue in the private sector. Cost and other factors came in. So that was not hugely popular, but we have been talking to the university, and possibly at least after the COVID situation improves, hopefully we'll be able to do that. And we also have something in mind so that we can start these cath lab based procedures in more wider scale. Let's see how we can proceed. Regarding the second issue that you were saying, popularizing these issues, what we are doing today is one such attempt. And I was planning to give the declaration at the end of the session, but let me give it now. From South Asian Association for the Study of the Liver, we are starting a series of webinars like Apasal is doing. So every month, the last Saturday of the month, there will be a webinar from South Asian Association for the Study of the Liver. On 29th of August, the first webinar will be there. We'll have international faculty and all the South Asian countries will be joining, and that will be on fat liver. And I think that these issues can be raised. We'll notify you, and we will expect you to be there. Regarding the nomenclature, there has been a recent paper that has just been drafted, where the authors include some eminent people like let me tell you, Dev Farrell is there, then Subrat Kumar Acharya is there, Dr. Go is there, to name it, Rajendra Reddy is there. So I happen to be a co-author of that review, which will be submitted, which we have submitted, where the title is Non-Alcoholic Fatty Liver Disease, Not Time for the Obituary Just Yet. So I still believe in NAFLD, not MAFLD, and so does many people. So unless that review is published, we are not in a very good position. But as you can see from the nomenclature, from the author list, I am a very minor player in that author list, but top hepatologists of the world, like Jeff Farrell and Sanjay Satpathy and people like them, they also feel that NAFLD should persist. So, so let's see how it evolves. But it's always good to do some brainstorming and things like that. So thank you, Farhad. Next, it will be Dr. Jumur Ghosh to give her expert opinion. She's an assistant professor of hepatology at MH Shamrita Medical College in Dhaka. Dr. Jumur Ghosh, please. Jumur, এটা আনমিউট করে নাও।
শোনা যাচ্ছে স্যার?
হ্যাঁ, শোনা যাচ্ছে এখন।
Thank you, sir. I must congratulate our both speaker, Dr. Pathopotik Roy and Dr. Ashik Ahmed Bhuiya, for the excellent and brilliant talk on the management of non-alcoholic fatty liver disease and hepatocellular carcinoma. Or we know that hepatocellular carcinoma is the most common malignancy in liver, and on the other hand, non-alcoholic fatty liver disease is the most common cause of cirrhosis of liver and hepatocellular carcinoma. Non-alcoholic fatty liver disease, or NAFLD, now called for hepatic manifestation of metabolic syndrome, is the great burden for world. So I think awareness about the risk factor for non-alcoholic fatty liver disease can help to reduce incidence and prevalence of the non-alcoholic fatty liver disease, and awareness about the risk factor of hepatocellular carcinoma, such as B virus, C virus transmission, and non-alcoholic steatohepatitis disease, can reduce the burden of hepatocellular carcinoma also. My opinion is about the awareness in the mass population to reduce the burden both disease. And both speakers also explained how it develop and how can manage, and how we can overcome this burden from how we will overcome this burden. And I have the question to Pathopotik Roy. You you have shown about the trial drugs, rovastatin, how this drug act in liver.
Dr. Partha, there is a question for you from Dr. Jhumur.
Let me share my screen again.
Jhumur, একটু কোয়েশ্চেনটাকে রিপিট করবে প্লিজ?
Sir, a new drug, rovastatin, on the liver.
পার্থ শুনতে পেয়েছে?
জি স্যার, আমি দেখাচ্ছি, আমি প্রেজেন্টেশন
আচ্ছা, স্লাইডটা একটু শেয়ার করলে। হ্যাঁ, থ্যাংক ইউ।
Dr. Jhumur, are you watching my screen?
Yes.
You are talking about this drug, resmetirom.
Resmetirom.
Yeah. This is a thyroid receptor beta agonist. So it works, I just say that with the pathophysiological mechanism of drugs. So this is where it is a thyroid receptor agonist work in this area, that this the metabolic pathway, that it thyroid receptor had some metabolic influence which ultimately perform some enzymatic modulation of different path of lipid and carbohydrate metabolism, especially in lipolysis, lipogenesis, fatty oxidation, beta oxidation, and gluconeogenesis. So that the concept of that drug came from that some scientists have found that that the thyrotropin releasing hormone and TSH has some effect on liver reduction of liver fat. For that, from that concept, they had developed a molecule that can act on thyroid receptor and act as metabolic pathways in different actions of liver.
Okay, thank you, Dr. Pathavat.
Thank you.
Thank you, Dr. Jhumur Ghosh. May I now request Dr. Dulal Dash, he's a hepatologist at the Department of Hepatology, Bangladesh Equity Medical University, for his expert opinion, please. Dr. Dulal.
Thank you very much. My teacher and mentor, Professor Mamunal Mahatab Shopil sir, for giving a nice opportunity as a panelist in such a webinar. Both the speakers are presented time-demanding topics like non-alcoholic fatty liver disease and hepatocellular carcinoma, which are more prevalent in our country and also in the world. More than 25 to 30% of people are affected by non-alcoholic fatty liver disease. They are also affected also in hypertension, diabetes mellitus, and also in dyslipidemia. And there are more in cirrhosis and hepatocellular carcinomas also by this disease, and non-alcoholic fatty liver disease also are more and more rising. Then they are presented updates management and this update nomenclature and management of hepatocellular carcinoma and non-alcoholic fatty liver disease, which is more prominent in nowadays. And we have much benefited this type of webinar. And I'd like to have a question, Parthopatik Rai, what is the mechanism of action in saroglitazide in non-alcoholic fatty liver disease?
Yeah.
Which is only used in the India?
No, basically this drug is first developed. The phase 1 study is done by Professor Sarin and his colleagues, but then phase 2 and phase 3 study by the other Indian scientists, and phase 3 studies in completed in India, and it was presented in 2018 ASLD meeting. And after the study of the phase 3 study, ultimately it was approved. They have applied, and ultimately it is approved in India. So it is a combined PPAR, paroxysmal proliferator activated receptor. There are 3 to 4 varieties of paroxysmal proliferator activated receptors: PPAR alpha, PPAR gamma, PPAR delta, and saroglitazar is a combined PPAR alpha, gamma, and delta agonist. So I have shown this in this picture, that what PPAR actually do. It act as a co-activators to formations of various molecules, enzymes, and proteins, which ultimately regulates at the molecular level, because these transcription factors occur in nucleus and ribosomes. But when these new enzymes and proteins are formulated, they go to cytoplasm and perform and modulate every steps of the lipid and carbohydrate metabolism. So ultimately, when the alpha and delta receptor, gamma and delta receptor of both PPAR is stimulated, then these parameters, fatty acid beta oxidation, ketogenesis, fatty acid uptake and oxidation, adipogenic and anagens, all have been modulated to an anti lipolytic or anti obesity parameters of visual. These two nuclear receptors act. Thank you.
Thank you. I also thanks Forum for the Study of Liver, Bangladesh, and BSMMU Hepatology Alumni Association to arrange this webinar. I also thank both the speaker and Professor Mamun Al Mahatab Shopin sir. Thanks.
Thank you, Dulal. Saroglitazar is actually this drug that is discovered and developed in India. It's the first drug that was developed in India. Now it is undergoing clinical trial in USA also for FDA approval. The US trial is led by Professor Arun J. Chanel. And in India, now the trial is led by Professor Duseja. When we had the webinar on World Hepatitis Day, if you remember, Duseja was speaking on saroglitazar. So thank you. May I now go to Dr. Pankaj Naha, hepatologist at Shoisarodhi Medical College, for his expert opinion, please. Dr. Pankaj Naha.
Thank you, sir, for arranging the live and for saying something. NAFLD and hepatocellular carcinoma both are time-demand topics. NAFLD is now a burning issue in recent world, as well as Bangladesh, and hepatocellular carcinoma is also important in early diagnosis and treatment option of selection of HCC. Thank you both Dr. Partho and Ashi. Both are present, both cases inside nicely. I have one query to Partho. Can you say me to the mechanism of lean NASH and its management?
Mechanism of lean NASH, I have said earlier that at a glance they are physically just not obese, that they unhealthy. So this metabolic come from very vast focus. Either there may be genetically predominant, such as some of the mitochondrial dysfunction, like there are some varieties of enzyme that community or some influence which creates insulin resistance in their body. So resistance to get the early detection of NAFLD and NASH, also despite they are non-obese. So they are genetic, it may be inflammatory, it may be auto-inflammatory, or it may be environmental. Thank you.
Oh, thank you, Partho, and thank you, sir, for giving me a chance to speak something. Thank you.
স্যার আপনারটা মিউট করা আছে স্যার, মিউট করে নেন স্যার, মিউট করা আছে স্যার, আপনারটা মিউট।
It's okay. Thank you, Dr.
Thank you, Partha and Ashik. Thank you.
Dr. Pankaj, may I request Dr. Nana Khale? She's a hepatologist for her expert opinion, please. Dr. Narwana Khale.
Thank you, sir. Am I audible?
Thank you. You're audible, Narwana.
Okay, first of all, I would like to express my heartfelt gratitude and thanks to my teacher and my mentor, Professor Mamunal Mathab Shopin sir, for giving me the opportunity to participate in this session as a panelist. And I would like to thank our both speakers, Dr. Partha Pratik Roy, who presented updated nomenclature and management of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, and Dr. Ashik Ahmed Bhuiya for presenting updated management of hepatocellular carcinoma. Both of the speakers presented, and thank you now, because the prevalence of these diseases are increasing. So I thank both of them. And finally, I would like to thank Forum for the Study of Liver Bangladesh and BSMMU Association.
Kumar Dutta, resident physician, Faridpur Medical College, is also a hepatologist for his expert opinion. Please, Dr. Pallav.
Thank you, sir, for this nice organization of nice presentations, both Dr. Ashik and Dr. Partha Pratik Roy, and also thanks to the Forum for the Study of the Liver and Hepatology Alumni Associations. I would like to add some speak with Dr. Partha, but there is a question from Pankaj Naha. What are the mechanism of NASH? In case of lean NASH, what are the mechanism? I want to add some points. There is alteration of the gut flora and the gut liver axis. This is the important cause for the lean NASH. There is some bad bacteria or some harmful bacteria increase in the gut.
For their nice presentation, and I will as most of the general physicians do not consider NAFLD as a disease. And regarding HCC, I would want to say we should create awareness among patients, as most of the we see most disease. So we stop repeatedly, so we can diagnose in early stage, as it is completely curable disease. If we diagnose the patient in early stage, we completely cure the patient. And also in ACC in Bangladesh, there are few centers. There is curative treatment is occurred, especially liver transplant is not occurred in our country, and also TACE and radiofrequency ablation occur in some private facilities. So I would request sir to arrange a lab in BSMMU for performance of the RFA and radiofrequency ablation. And I would like to also thank Forum for the Study of Liver and Hepatology, BSMMU Hepatology Alumni Association. Thanks all for question hearing.
Thank you, Dr. Afzal. Before I conclude, I see Dr. Abdul Rahim on the screen, the General Secretary of BSMMU Hepatology Alumni Association. He has been listening to the proceedings very carefully and cautiously. May I request him to please convey the vote of thanks before I conclude the session. Rahim bhai, to unmute karen and
Can you hear me?
yes.
Thank you all the participants and all the audience of Hepatology Bangladesh. This is the probably 12th webinar from Forum for the Study of the Liver and also Hepatology Alumni. I thanks Professor Mamunal Mahatab Shapin sir for this opportunity to arrange this webinar and aggregate all the hepatologists and took part. And I also today I please our hepatologists Partho and Ashik. They present their topics very deliciously and comfortably, and also before today there was also another webinar which was presented Utpal Dutta. They also presented very nicely, and in this way we are arranging our hepatologists very precisely, and they will make previous for the next time they are presented their topics very sincerely, and it will be our alumni and Forum for the Study of the Liver facilities. And I also thank Professor Mamunal Mahatab and all the hepatologists. Thank you, sir.
Thank you, Dr. Rahim bhai. Before I conclude, my feelings. Yesterday I turned 50. So see, I was very upset yesterday because until day before yesterday, I had considered myself very young. But when I turned 50 yesterday, I realized that I have finally joined the boat of departure. So now now it is time to wrap up and pack up. But then in today's webinar, I was very satisfied because all the speakers are my direct students, and all the panel members are my direct students. It is very satisfying as a teacher to see the moderator session where your students are speaking so elegantly and delivering world-class lectures, and seeing your students being